Sure. As you know, benchmark study in peripheral cholangiocarcinoma was reported. The study included low-risk patients from 24 expert centers uh, in the world. The procedure was limited to major hepatectomy without vascular resection. A total of 708 patients were included as benchmark cases, and the reported benchmark values were Clavien 3A or more, 70%, Byrix 47%, laparotomy 90%, and 90-day mortality 13%. This morbidity and mortality rate in surgery for peripheral cholangiocarcinoma was higher than other benchmark series in HVP surgery. In Nagoya University, 46 patients underwent hepatectomy with and without vascular resection between 2011 and 2020. Clavien 3A was developed 63%, and viral leakage was 33%. These incidences were similar to benchmark's value. However, laparotomy and 90-day mortality rate in our cohort were much lower than benchmark value. This table lists postoperative complications after hepatectomy with biliary duct dissection in our university. In order of the incidence, viral leakage was the most common complication. The incidence rate was 33%, and followed by intra-abdominal abscess, liver failure, cholangitis, pancreatic fistula. The incidence of vascular complication, hemorrhage or thrombosis, was about 5%. We previously reported viral leakage after hepatobiliary resection in detail. According to the ISGLS definition, grade A was found in 5%, grade B in 33%. No patients had grade C. In other words, all patients were treated by non-surgical intervention. A median time to drain removal was 29 days. Almost all viral leakage originated from the liver transection. Hepaticojejunostomy breakdown was found in 3% of patients. Lastly, left trisectionectomy was a high-risk procedure with an incidence as high as 44%. Although most viral leakage is treated successfully by drainage, we sometimes experience refractory viral leakage, which cannot be treated by simple drainage alone. Viral leakage from isolated bile ducts, which does not communicate with the biliary tree, is likely to be intractable and results in a longer hospital stay. We sometimes experience refractory viral leakage. Most patients with refractory bile leakage of bile leaks from isolated bile ducts. We have performed external ablation for bile leakage from isolated bile ducts. Between 2007 and 2016, 31 patients, 5% underwent external ablation. A median time to drain removal was 62 days after surgery and 28 days after first ablation. We experienced some mild adverse events, such as transient fever, mild pain, flushing, or small liver abscess, which was treated by antibiotics alone. No serious complications have occurred. The patient was a man who underwent left trisectionectomy with extrahepatic bile duct dissection. Isolated bile ducts were identified by fistulography. A guide wire was advanced into the bile duct. The catheter was inserted into the bile duct and absolute ethanol was injected. Ethanol injection was repeated 4 times. And then the bile duct was completely ablated and bile leaks resolved. Pancreatic fistula is well-known complication after hepatopancreatitis. But pancreatic fistula also occurred after hepatectomy with bile duct resection. In the previous study, we reported 10% of patients who underwent hepatectomy with bile duct resection developed grade B pancreatic fistula. No patient had grade C pancreatic fistula. Median time to drain removal was 31 days. Lymph node dissection around the pancreas, number 13, and intrapancreatic bile duct resection can injure pancreatic parenchyma. This leading to pancreatic fistula. In our experiences, 10% of patients had post-hepatectomy liver failure with 7 or more of total bilirubin value after surgery. Failure to rescue rate in patients with PHLF were as high as 18%. No specific treatment exists for this liver failure. Therefore, prevention is the best treatment. Previous studies reported that insufficient volume of the remnant liver, intraoperative massive bleeding, impaired blood flow, and infectious complications are risk factors for PHLF. Of them, what we can do to prevent liver failure after surgery is management for infectious complications. There are some differences between hepatectomy with and without biliary reconstruction. One of the differences is the extent of surgical field contamination. Patients with peripheral malignancy are often undergo preoperative biliary drainage, which causes bile contamination. surgical field is contaminated by bile during hepatojejunostomy. As a result, surgery for perihilar malignancy is classified as contaminated surgery. In contrast, bile contamination or bile spillage is uncommon in hepatectomy without bile duct resection. Once again, we show the list of postoperative complications. Infectious complications, especially surgical site infection, account for most of postoperative complications after hepatectomy with bile duct resection. Uncontrollable infectious complications are likely to cause liver failure, and liver failure worsens infection. They form negative spiral and may result in mortality. Therefore, we believe adequate drain management to control SSI is one of the most important ways to prevent progress of liver failure and mortality. From now, let me introduce drain management strategy in our institution. First, I will talk about surgical drain placement. This figure shows the standard drain placement in right-sided and left-sided hepatectomy. In principle, 2 or 3 drains are placed near hepatojejunostomy and liver transection drain. And in right-sided hepatectomy, another drain is placed at the right subphrenic space. The policy for drain placement is that one, using closed suction drain. And second, we pay attention to placing drain as straight as possible during surgery. If not placed straight, drains can be dislocated postoperatively. Drains are sometimes dislocated. Dislocation will occur when drains are pushed out by other organs, such as the transverse colon or small intestine. We have experienced drain dislocation in especially obese patients. There are 2 papers investigating drain dislocation after pancreatic surgery. Marchegiani et al. Showed drains were dislocated in as high as 33% of patients who underwent pancreatic resection, and 77% of dislocation already occurred on POD1. In another study by Lee et al., drain was dislocated in 24% of patients who underwent distal pancreatectomy. The incidence of clinical relevant POPF was high in patients with drain dislocation. The next is Nagoya style postoperative management. The slide shows the schema of postoperative management in our institution. Prophylactic antibiotics are administered for 2 days after surgery. After that, antibiotics is used on demand. Surgical drains are placed for at least 1 week. Drain fluid is closely inspected every day and sampled for total bilirubin and amylase value and for bacterial culture on POD 1, 3, and 7. PT is routinely conducted to survey abnormal fluid collection on POD 7. Drain removal is considered on POD 7. Drain removal is determined based on the 4 findings. Drains are removed on POD 7 when all of the following 4 findings are met. Grossly clear, biochemically normal, no bacteria detected on gram staining, and no evidence of abnormal fluid collection on CT. Otherwise, drains are exchanged for a new drainage catheter. Thereafter, the drainage catheter are exchanged once or twice a week. Between 2012 and 2018, 374 patients underwent hepatectomy with bile duct resection. Patients who underwent HPD were excluded from this study. Patient characteristics are shown in this table. Major hepatectomy was performed in most patients. The number of right-sided hepatectomy was approximately equal to left-sided hepatectomy. Combined vascular resection was performed in 35% of patients. A median duration of surgery was 546 minutes, and blood loss was about 7 milliliters, 1,000 milliliters. The number of placed drains is shown. About 70% of patients had 3 drains. Some patients had up to 5 drains. In this study, bile leakage, pancreatic fistula, and intra-abdominal abscess were grouped together as syrup. A syrup was developed in 50% of patients. Grade B or C liver failure was found in 11% of patients. 90-day mortality was 1.3%, and failure to rescue rate in patients with syrup was 1.6%. The slide shows drain management for syrup and postoperative course. According to the rule, drains were removed in 166 patients, and drain exchange was performed in 208 patients. In patients whose drain was removed, 21 patients underwent additional intervention for suspicious syrup. On the other hand, in patients who received drain exchange, Drains were eventually removed due to no signs of serum in 34 patients. In summary, uh, underdiagnosis was found in 9.6%, and overdiagnosis was done in 16% under postoperative management based on awareness. This is the diagnostic ability for predicting therapy. The diagnostic ability based on drain fluid findings on POD3 was inferior to POD7. These results showed early drain removal may be inadequate. On POD7, adding CT to drain fluid finding increased the sensitivity and negative predictive value. Our rule worked well as a safe drain removal criteria. Our drain management is so-called delayed drain removal strategy, featured by longer drain placement and strict drain removal criteria. And this strategy may increase unnecessary drain exchange and placement. It is problematic, but the concept of Nagoya rule is not to miss even minor leaks or corrections and to prevent lethal complications classified as preventing grade 3B or more and better to rescue. If doubt exists, drainage is our policy. In summary, we experienced high morbidity and mortality rate in complex hepatobiliary resection. The main complication in hepatobiliary resection is infectious complication and liver failure. Adequate drain management is critical to decrease mortality or failure to rescue. The delayed drain removal strategy based on our rule is safe and feasible in complex hepatobiliary resection. Thank you for your time and attention.